Jesheena for that wonderful videos. Now we have implanted the IOL and now we'll see next post-op day what is happening. I invite Dr. Jesheena to give her talk on post-op assessment. Jesheena is a phacosurgeon at Comptress Eye Hospital. All of us are colleagues there.
Good evening. My colleagues already explained about the patient selection, patient workup, patient education, and IOL implantation. My topic is post-operative management. Even after uneventful post-op, most of the 70% of the patients, only 70% of the patients will be happy. Remaining 30% of the patients have some form of remaining refractive error. So, how will we proceed? In happy patients, we have to check uncorrected visual acuity and best correct visual acuity, whether they have achieved targeted vision, expected target vision. Then we have to dilate and see under slit lamp examination. Look for anterior capsule rhexis cover over the IOL. Look for the gross centration of the IOL by comparing the toric IOL marks with the pre-op implantation access sheet as reference. There is no need for look for minute degree to degree alignment. Many slit lamp can tilt the measure and thin slit beam of the light, which can be aligned with the toric markings, that is dots on the IOL optic, to estimate where the IOL is now oriented. You can turn the slit lamp to thin slit beam of the light to align the IOL marking. So, patient IOL is aligned at 180 degree. Then coming to the unhappy patients. So we have to check the vision and best corrected vision and acuity, and also accurate subjective and objective refraction. Then slit lamp examination to verify the axis, whether it is in the targeted position or not. And repeat keratometry, biometry, and IOL power calculation. Then if axis is as planned, but there is astigmatism is there, then it may be due to poor or incorrect biometry, or uncorrected for posterior corneal astigmatism, or it may be due to wrong IOL, or it may be due to surgically induced astigmatism. So there are online calculators available like astigmatismfix.com, iTrace, or Barrett RX Analyzer, or assort.com. Then how will check in the astigmatismfix.com? We have to enter the doctors and patient data and which eye and the IOL power and current refractive status of the patient, and also the IOL power and model, and then click the calculate. Then we'll get the picture like this. Here the patient IOL was oriented in 28 degree, and now it is there is some error was there, so it have to rotate 12 degree. Then coming to another case scenario, here the optometrist flipped down the axis. Actually, her K1, K2 was K1 was 41.2D at 89, and K2 was 47.2. She flipped the axis in the toric calculator, and the axis code was at 89 degree. But after follow-up, patient UCVA was 624 and BCA was 66 with plus 2.75 and minus 0.5D at 90 degree. So when put the data in the astigmatismfix.com, the axis was not in 90 degree, it is actually it has to be redialed to 180 degree. So, realignment of the toric IOL is needed in cases more than 10 degree of rotation from the target axis. A rotation of less than 10 degree changes the manifest refraction only by 0.5 degree diopter and usually does not warrant any additional intervention. For every one rotation, 3.3% of the lens cylinder power calculation is lost. For 30 degree rotation, there is complete loss of astigmatis error correction, and more than 30 degree additional astigmatism or visual problem will develop. When we will do redial, only after 1 week is ideal, otherwise re-rotation will occur. So here there is one patient with 67-year-old male patient. His K1 was 39 at 86 and at 86 degree. K2 was 41.6 at 178 and axillary, and IOL power was 20.D. First day his vision was 6.6. 1 week he came with vision was reduced to 6/24, and his BCA was 6.6 with this correction. So his initial IOL we calculated in the Alcon online calculator. It was 177 degree, but it was on was 1 week when he came. It was at 130 degree, and when it's checked, we have to rotate to 179 degree. So how will rotate? First we have to inject cohesive visco, then we have to make ensure that there is no adhesion between the capsule and IOL, then dial in clockwise direction till up to less short of 10 degree of the target axis. Then wash the visco and final adjustment or refine with either irrigation probe or you can use dialer to fine adjustment. Then giving a central tap also give a addition at the center. Then hydrate the wound tightly so that IOP is slightly higher than normal, and it will prevent further rotation. Then what is the importance of subjective refraction? We can calculate the spherical equivalent error. Here the spherical equivalent is error is 0.25. So if more than 1 degree, 1 diopter only, we have to do for IOL exchange. Otherwise always rotation is preferable. Sometimes IOL rotation or exchange may not be helpful to make patients happy. Glasses or PRK or piggyback IOL may be needed. So take home messages, always compare with pre-op UCVA. If the patient is having bilateral cataract, in the post-op cover the operated eye and show the vision in the unoperated eye first, then show the vision with the operated eye. This will help giving the wow factor to the patient. Any realignment of the IOL to be done after 1 week or usually 2 to 3 weeks. After 8 weeks, it is difficult to realign because of the fibrosis of the capsule. So after giving, after a good post-op and patient is getting a 6/6 vision without glass, patients will be happy. We will also happy. Thank you.
Thank you, Jesheena, for the troubleshooting mechanisms in toric IOLs. Now I invite Dr. Vijayalakshmi for the special situations to discuss on.